Good morning. So she already gave you a little bit of an introduction. I've been doing these suicide prevention, intervention, etc. trainings for a few years now. Largely I do the 6-hour training that is for counselors across the state that is required. So this is going to be an extremely condensed version of that, like very, very much smaller than that. So we're going to focus on education surrounding suicide. What is appropriate language that we use? How do we talk about it? We're going to not just learn about suicide as a whole, but also how do we look out for ourselves, for our colleagues? How do we take care of ourselves as providers who are working with clients who are experiencing things like this? And then we'll talk about what are some practical steps to apply to really make this something we can do something about. So I'm not just going to present the problems. We're going to talk about, well, what do we do about this? So with such limited time for this presentation, there will be a lot left unsaid. There'll be a lot of answers that we won't really get to. I do invite feedback. Typically, these are pretty interactive trainings. It doesn't always lend itself to that. The setup doesn't, but please speak out. I am not the expert at all on problem gambling and working with clients who are dealing with those things. I have some statistics and things we'll talk about, but that's not my expertise. I invite questions, discussion, sharing of information and what you guys know on that. I know way more about just clients in general dealing with suicidal ideations and behaviors like that. So let's get this rolling. Yeah. Okay. Nope. There we go. So here's an overview of what we're going to do, which I already covered a little bit. Here's where we're starting, just general information. We're going to look at U.S. and state statistics. We're going to then talk about, well, what do we do with statistics? It's great to know them, but then what? We'll go over language. We'll talk about warning signs and risk factors. This is where I may want some feedback and participation from you guys too. Have you seen this? What is it like working with your clients who are dealing with these kinds of things? What specific, maybe unique warning signs or risk factors do you notice? Then we're going to jump to awareness of self, thinking about how this affects us, how we show up, what do we do about that? We'll talk a little bit about chronic stress, secondary traumatic stress, and that's for us as the providers. So just things to be aware of. We can kind of click into our clinical minds and our actions and just roll with the punches, but this is real stuff. This is heavy stuff. It affects us. And so we want to just be aware of those things to look out for ourselves, look out for others, and what do we do about it? I'll pause here for a second too and say it is first thing in the morning. We are just starting out. This is a heavy topic. So please take care of yourselves. Take some deep breaths. Step out for a second. Whatever you need to do. It's not like class. Yes, do your ohms, do some yoga, whatever you need to do. It's just a lot. I try to liven it up a little bit. That's just who I am anyway. So obviously that means no disrespect. It's just we cannot just sit here with a solemn, mellow tone the whole time. That would not do any of us any good. So be nice to yourselves. Doodle a little bit. Whatever feels appropriate. Of course, as an art therapist, I'm going to tell you to doodle like it's nothing. So then we'll talk about, okay, well, what are best practices? What are things we need to put in place to actually work with individuals who are dealing with this, to look out for ourselves and our colleagues in our workplaces? A little bit about pathways to care, but then also the ever-important legal and ethical considerations. It can feel kind of tough to have to talk about that when we're talking about working with individuals, but it is obviously a huge part of this too. What do we do about that? How do we look out for ourselves? Ask questions. Feel free to jump in and just raise your hand, say some things. We can be a little interactive throughout. So why might we need this? Well, for one, ourselves. We want to be informed. We want to be able to show up as our best selves when we're working with clients. We also want to look out for ourselves personally. What if we start to experience some of these things, or we start to experience this chronic stress that then can lead to ourselves experiencing suicidal ideation or experiences? That's one thing I want to say too in terms of being kind to yourself, looking out for yourself today. This isn't a topic that just addresses or affects people we work with. This could have affected us personally. This could have affected those that we're close to, people we know, friends or family. So we just need to be aware of how to look out for ourselves, how to look out for those that we care for, and recognize this is a real thing that happens. It is not a thing that is to be stigmatized. There's nothing wrong with someone when they're experiencing this. It's just a specific set of circumstances that is predispose them to experiencing this right now. So really working to destigmatize and take away the shame from these experiences. And then obviously our clients. So what do we want to look out for them? How do we want to best help them and show up for them? Okay, so here's some statistics. Yeah, it's quite small, a little blurry, but I'll tell you guys some of the high points. So for one, it is the 12th leading cause of death in the U.S. It is varying, well, I'll just tell you, for teenagers, it's the third leading cause. Ages 20 through 34, it's the second. 35 to 44, it's the fourth leading cause. More so than that, I think it's important to pay attention to this bottom left part where the little brain is. 10% of adult Americans have thought about suicide. 1.2 million have attempted suicide. There's obviously a lot of people that live in the U.S., but that is a huge number. And we don't always know, we're not always aware of that, right? There's probably so many people that we interact with that have experienced something like this, and we're not aware because it's not something that is as openly talked about. 54% of Americans have been affected by suicide in some way. If we take a second and think about that, I think that makes sense, right? Think about, I mean, I can think about obviously clients, but even beyond that, people that I know just outside of my work. So let's see what else is important. We're going to talk a bit later about like creating safety, access to lethal means, things like that. So an important setting point for that, 54% of firearm deaths were suicides. So just firearm deaths, period. Over half of those were suicide. And then kind of on the flip of that, 53% of all suicides were by firearms. So that tells us that's a key thing to pay attention to when we're looking at lethal means safety and creating a safe environment for someone. We'll look at statistics for Kentucky specifically. So our state rank is number 19, so we are 19th in the list of most suicides. I've seen like a graphic before of all the states. We are kind of like mid-range, so we're not on the low end at all. We're not the highest, we're about mid-range for rates of suicide. There's some interesting things to look at in terms of that. So a lot of the western states have higher rates of suicide per population. When you think about that, there's not a lot of access to care. There's a higher, I don't know what the right word is I want to say, but a higher number of people have access to firearms, right? Hunting, safety, all of these things. And a lot of the communities are rural, so there's not a lot of access to care if they wanted to access it, nor is there access to someone who's going to screen them for suicide risk. Speaking of that, 75.11% of communities in Kentucky do not have enough mental health providers to serve the residents as of 2 years ago. That's huge. That is a huge percentage of our communities in this state. Even working in Louisville, where it is plentiful. There are so many psychiatric hospitals, private practices, community mental health, all of those things. We still don't have enough to go around. Like in my private practice, we still have people on the wait list for months. So even when you have a lot, it's still not enough. We have people coming from a few hours away to access our crisis services sometimes. So that is a huge issue when it comes to access, prevention, planning, caring for these individuals. Does anyone have thoughts about any of these statistics if you can read them? I guess they're on the TV, so you can read them a little bit better there too. Yeah. In terms of gambling specifics, about 20% of gamblers will attempt suicide in their lifetime. Addicted gamblers have the highest suicide rate among all addictive disorders. And if we take a second to think about that, I think that makes sense, right? Think of all the repercussions. Think about the havoc they may realize that has been caused on their own lives, of those around them. When we get to warning signs and risk factors, we'll talk about this a bit more, but one of the primary ones is feeling like we're a burden on others. If a problem gambler has a family, they're definitely going to feel like they're a burden to them. So this seems like a pretty easy escape. One thing I really want to impress upon you guys is thinking about how can we understand the mindset of someone who's experiencing this? How can we understand this as like a solution to all of their problems, right? There are plenty of solutions, but for a number of reasons, that's the one that they're focusing on right now. So we want to work to understand like what has kind of come to be for them to think like, yes, like this is the solution. Can anyone else think of reasons why that might be really high in this population of clients? Anyone have experience working with clients who are dealing with these kinds of things?
alienation of support groups.
Oh, for sure. Yeah.
And there is a lower willingness to seek out help because there is a public stigma on gambling as a moral failing and not a behavioral issue.
And then let's combine that with the shame of just mental health access in general and asking for mental health help. And then on top of that, the shame of having any suicidal thoughts.
And the low amount of professionals that are certified in working with this population.
Absolutely. Yeah. So it can seem insurmountable. These things are not, but it can very much feel that way. Yeah. So a little more about statistics. And I know the second two are not about gambling specifics, but they're just important things to note. So, like, one of the highest statistics that always sticks out in my mind is the second one about, well, actually not that one. The third one. So, not even just within the year of their death, but individuals who die by suicide have either visited their primary care doctor or have been to an emergency department, sometimes within the last month, definitely within the last year. They're not always accessing mental health supports. And so a lot of times I'll do these trainings with like nurses, healthcare workers, hospital professionals, and a big focus there is how screening needs to be just like across the board, like universal screening for suicide risk. It may feel like weird or not, like why are we gonna ask about this when we're like taking their blood pressure? Someone has to, and they're much more likely to answer it in those scenarios than they are to just reach out on their own. So if we just put universal screening across the board in healthcare settings, it's gonna cut down on a lot of these things, or at least provide the opportunity. So there can also be the myth that if we ask about suicide, we're gonna suggest it. Research has proven that is not the case. It is not the case. The worst that's gonna happen is they're just gonna say no. But then they know that there is an open door, there is somewhere and someone they can go to talk about this if they have to, if it does come up for them. So we can have our own fear about asking these questions and what we're gonna elicit or what we're gonna suggest. That's not the case. We don't need to be concerned about those things. There are endless statistics in the world that you can find about information about suicide, about individuals dealing with these things, but it's also like, well, that's all well and good, but what do we do about it? So we're gonna hit a few different things. First, we're gonna look at language, how we talk about suicide. We want to be sure that we have sensitive, precise, accurate, non-stigmatized language when we're discussing these things. And that is in our work, and that's also just in our lives at large. So I've noticed myself, I don't want to say correcting people, but like a little bit in my everyday life if I hear them saying some of the things that we talk about on here. Because as professionals, especially mental health professionals, that's kind of our role anyway, is to like further that education even when we're not in the workplace. So we're going to talk about that. We're going to look at what to look for, so that's warning signs and risk factors. And if you guys want to add to any of the lists that we'll have on here, please speak out. It's good to learn from each other. How we react, looking at awareness of ourselves, it's a big part of it. Of course, as a therapist, we're going to have to talk about that, right? I can't just be like, here's the information, let's carry on. So we're going to talk about how we show up. Even as informed, if you are a therapist or someone working in the mental health field, even though you're educated and informed, that doesn't always translate to like how we kind of take care of ourselves and look out for ourselves in these situations. So here are just standard definitions from the CDC. We used to have to explain what the CDC was in doing these trainings. Not anymore. Everyone knows who that is. So suicide is just strictly what happens, a death caused by self-directed injurious behavior with any intent to die. But sometimes it can be when it's like accidental as well. But if it is like self-directed violence, a big thing about suicide deaths is a lot of times they are impulsive. So maybe someone was intending to just have an attempt, was not maybe thinking it really through, but they can still cause a death by doing those things. Suicide attempt, a non-fatal, self-directed, potentially injurious behavior. This is just in how we're going to describe these things. This is just a start with how do we be precise and accurate when we're talking to people. We don't want to say things like, oh, somebody was just like crying for help, you know, or, oh, they're just like, as people will say about teenagers more often is, oh, they were just trying to get attention. I don't really care what they were trying to do. If they're doing something that's causing harm to themselves and potentially death, that's what matters. Like, I don't care if it was to get attention. We'll deal with that later. Suicidal ideation, thinking about, considering, or planning for suicide. So the top one is more so what you'll hear as just like self-harm or cutting or something like that. And a big part to that one that I want to point out is it is a risk factor for suicide. It is not an indicator that someone is feeling suicidal. So if someone comes to you and they're thinking about this or have done this before, or if they've done it in the past, maybe not right now, just keep in mind, like, okay, they may have a higher likelihood of experiencing suicidal thoughts. You don't want to immediately jump to, oh my gosh, this person needs to go to a hospital. That's not it.
It could also be a coping skill for that individual.
Absolutely.
So we don't want to immediately jump and trying to resolve this without replacing that with a more effective.
Yes, yes. Because it is an effective coping skill for a lot of people. And it does fall under a lot of the similarities of other addictions. That's a lot of times how I'll treat that with people who are kind of experiencing that for a long time in their lives. So definitely something to pay attention to, not something to totally freak out about. It may feel weird to say that and hear that, but it just is. Preparatory acts and other suicidal behavior. So this is where they are actually making preparations, but maybe it's interrupted, which is the next one, an interrupted suicide attempt. So this may be where someone say it was like a failed suicide attempt or unsuccessful. We're gonna get away from those words. Interrupted suicide attempt, either by themselves or someone else. So I think the next one, yeah, this is where I like to focus a bit. These are ones we are just trying to learn and trying to move away from. So the top one is one that is more so changed over time. I have seen more change in that more commonly. There are regulations around like reporting and journalism around suicides that have changed a lot of these things too. But really, if we're thinking about it, we're thinking, okay, we're trying to frame suicide as just another health condition. It is not like a behavioral act that someone just chose to be selfish, as some might say. It is just something that happened. As someone died of a heart attack, they died of a suicide, or they died by suicide. We're really trying to humanize what's going on. We don't want to other people who are dealing with this. We don't want to talk about it in that way to even people who aren't dealing with this. What if someone in their lives died by suicide? We really want to be respectful and understanding and want to be all on the same team. So we don't want to other them in talking about these things. We want, in case it's not clear, the ones on the left are what we want to say, the ones on the right are what we don't want to say. So typically we've heard successful or unsuccessful suicide attempt. I've heard clients come in and say, I tried to kill myself and I couldn't even get that right. So if we are saying that they were unsuccessful, that just feeds into that. And we don't want them to frame it like that either. So this is language for us just as people in the world and as working individuals. We also want to help clients understand it in this way too. So suicide death, suicide attempt. One way that can help think about these things is we're trying to be very precise and factual. We're not putting like a value judgment on anything. So successful, unsuccessful, like why are we describing something like this with those terms? We just want to be direct. That goes also with describing the behavior. So we don't want to say someone was manipulative or attention seeking. We want to just say what happened. This is when you're thinking about like communicating to a coworker, communicating to, let's say you're having to refer someone to a hospital. You want to just say the facts. You're not trying to make a value judgment. You're not trying to interpret what's going on or why they did it. You just want to say what's up. The bottom one, working with versus dealing with. So we obviously, this is thinking about saying this out loud. So we don't want to go into work and be like, oh, I got to deal with all these suicidal clients today. Or any other like mental health condition, right? We don't want to say we're having to deal with all of these people. We're working with them. And think about how that can sound and feel different in your own mind. If you say, I'm working with so-and-so who is experiencing these symptoms, right? We don't want to say to ourselves, oh, I got to deal with all these people for 8 hours today. That's going to feel a lot heavier. That's going to shift your perspective in a more negative energy space, and that's not helpful. There's more and more, obviously, we can discuss about these things. So this is an ever-changing thing. I think it's our role in culture and society to be part of this change too. So if your friends are talking about it or whoever, it's okay to be like, actually, we don't say committed suicide anymore. We say this. It just eats me up inside when I hear these things now. Anything else anyone want to say about language, how we talk about this? We're going to look next at like warning signs and risk factors. So just before we step ahead. You guys can also share like experiences, anecdotes, anything like that. That'll be helpful too. We'll be able to stay on track with time, I promise. Okay, so we're going to talk about warning signs and risk factors. So these are just the general ones that we will hear about and you read about. Some of them I have trouble with because, so like warning signs, the second one, researching information about suicide would be the rest of that sentence. Yes, obviously, that is a warning sign. How often do we like know that? Or are we aware that someone is researching these things or preparing? So some of the warning signs are good to know in case they come up, but we can't rest on those and think, oh, well, I don't know, I haven't heard them talking about it. I haven't really seen them like researching anything or like buying weapons or like saving their medications. Like I haven't seen any of that, so like they're fine. So good to know. We don't hang our hat on them. It says talking about these things like feeling hopeless, no reason to live, etc. I think we can also just go on our intuition, maybe our observation about these things. Maybe they're just seeming more hopeless in the way they're talking. Maybe they're just not really talking about the future very much or really just talking in a very negative kind of final way about kind of their reasons to live. We want to just have these little red flags pop up for us. We don't want to just wait for them to say something, which is a big thing that we will talk about. And I wish we could spend more time on it today. Probably have to take a longer training. But in how we talk with individuals about this, what do we say? How do we ask them these questions? We'll get to practical stuff later, so I won't get too ahead of myself. But thinking about it is the role of the provider to ask these questions. A lot of times they're waiting for us to ask them. I've been told that by clients, and that's just like, it is so helpful for them to know that we are comfortable with it, that we can talk about this. We are the open forum for it, and we're a safe place for it. Because who wants to just like bring this up? Like very few people want to just be like, hi, this is what I'm feeling and thinking. Isolation or withdrawal, that's we can recognize that. But also let's think about the ones more at the bottom of the list. I think those are more observable. A lot of changes in sleep habits. Impulsivity, if they are experiencing more risk-taking behaviors and impulsivity, suicide attempts are also highly impulsive. And so a lot of suicide deaths come from not where someone planned for it, but where it was just like something happened, they did it. Maybe they didn't actually think. If they had had time and space and distance from acting on it, they may not have wanted to follow through with it. So if you're noticing an increase in impulsivity, that is huge to pay attention to. All of these risk factors, legal problems, serious financial problems, those obviously make sense in this situation. Feeling shame, knowing like how they're affecting others in their lives. Can you guys think of other ones that would be specific to this population, this clientele?
Relationship stressors.
I would think like having to be dishonest with with people they're in relationship with, yeah.
A general one or two would be recent hospitalization or medication change onto an antidepressant for a lot of individuals that are experiencing depression or in these types of scenarios. They don't really have a level of energy. So once you start them on an antidepressant, they now have energy to actually act on these thoughts.
Yes, and they maybe they haven't been in such a headspace to like work on all the other stuff yet, so they're still in that depressed like cognitive state. And so they have more energy, and then that's definitely a situation where that can be much more likely to occur.
But money loss. Would be a big one.
Yeah. The threat of it. I think all of these things can like feel so insurmountable, and so they're huge risk factors. I think about the guilt and shame and secrecy of this too. I mean, that's huge in like keeping us stuck and affecting mental health concerns that people have, especially affecting suicide. It all just like compounds on each other. Okay. Yeah, maybe more readable on the TVs. So one thing that we want to pay attention to is that this is not an outcome that, or it is an outcome, I'm sorry, that requires several things to go wrong all at once. So it's not typically going to be like this one thing happened and then they experienced a suicidal crisis. That's not really how this goes. So we want to think about this first section. These are things that, well, really the first two. So things that predispose, maybe set up a person just in general to be more likely to experience certain things. So I'm not sure if you guys, some of you probably have, but been educated on ACEs, adverse childhood experiences, all those trauma-informed care things. So basically, if you haven't, anyone who has experienced trauma as a child, there's a whole list of them. I'm wondering like what we're going to add to them because this list is kind of old. I feel like there's many more we can add at this point. But have experienced trauma in their childhood, they are much more likely to have many healthcare things go on, physical healthcare things, but they're much more likely to experience suicidal ideations at some point in their lives. So we want to just pay attention. If we're thinking of risk factors, they're just want to cause little antenna to go up for us. Just like, okay, this person's had early childhood trauma. I want to maybe stay aware of what's going on with them. I may want to ask questions more often than I think I should. I may want to ask about suicide or self-harm or any thoughts like that. Thoughts of wanting to go to sleep and not wake up, like whatever like hierarchy of severity you want to ask. But if we know those things are going on or have happened, we may want to pay more attention to it. So those are all just kind of the setting events in a way. It's kind of the setup for like what things are already going on that could cause this to be more likely for a person. So then if we're thinking about, okay, we're getting closer to a suicidal crisis or action occurring, let's pay attention to these things. So if they are just hopeless, if they are intoxicated or are more frequently becoming intoxicated, if they have a tendency towards impulsivity, towards being aggressive, if they have just a very negative, dark, hopeless mindset, if they have severe chronic pain, that's physical, but let's also just think of like psychic pain, just severe, unrelenting, just like will not go away in their minds. Those are factors that are going to just go on top of these first ones we had and make it a lot more likely to happen. So if we have all of these things going on, our red flags want to be like way up, waving in the air. We want to be doing something. So then we want to very much pay attention to these immediate triggers. So what are these things that could cause it to like happen, could cause someone to like act or follow through or attempt? So public humiliation or shame, I feel like that's a decently high chance in this population. Access to weapons, that's a tough one in terms of like creating safety in their home or wherever they are. We'll get to those things. But it is key to think about that, and that's like the number, if we can do anything to preserve someone's safety, that's like the number one thing. We saw those statistics earlier of the chances of that happen when we have access to firearms. They experience defeat if they have a major loss, a worsening prognosis, obviously of a healthcare condition, but obviously with anything, right? Like just seeing a situation or something coming up to them that just causes them to be, that just seems more insurmountable, that seems like, well, this is literally just only going to continue to get worse. So this is not meant to like scare us or stress us out too much, but I do want to like sit with that for a second. So this is a lot of information about, here's all the scary stuff that goes on. Here is what can predispose a person to feeling like this. Here's the things we can just see and observe with our clients. That can cause a lot within us. So just think for a second, pay attention to yourself. What are you experiencing? Sorry to be a therapist, but we got to pay attention to it. So like my stress level feels a little higher. I talk about this all the time, but every time I do a training, every time I work with clients, I'm just like you just feel it because it is heavy. It's big stuff. And even if I talk about it in a clinical way and I'm doing all the right things and I'm setting up safety for my clients, it's still just a lot. Working in crisis, so I was full-time working with children and families in crisis for like 7.5, almost 8 years, through all of 2020 and 2021, or most of 21. So that is a lot of 40-hour weeks talking about suicide. And so I knew what to do, right? Like I'm just doing it, going through the motions, like setting people up for care. Working for community mental health, we have a lot of resources. So it didn't just fall on me. There was a lot of support around us. So that was really helpful, but I did not realize until I'm not doing it every day, the level of stress that it caused. I did not feel stressed. I mean, sometimes, obviously, paperwork and like all of those things. But largely, we're just like going through it, right? It's our job. And that's with any job. It's not even just like working with clients. It can be any career where we're just constantly going through this like stress state without really paying attention to it. So it's critically important to pay attention to what we are feeling. Does it bring up fear for us? Does it bring up past memories, either about ourselves, about those we're close to? Does it trigger past traumas that we've experienced? Does it trigger past stressful times? What does it hit for us? Then we need to know what to do about that, right? How do we care for ourselves? How do we make sure that doesn't continue to cause any effects on us? We want to think about this for ourselves personally and how we exist in our lives, but also in just how we're working with our individuals. So let's think a little bit about just our awareness of ourselves. So this is thinking about when we're specifically meeting with a person who's experiencing some risk of suicide or whatever kind of crisis is coming to us. So this is ideally what we would have time to think about. How do we feel today? How is our day? How's our day been going? Have we had so many things going on? Do we have a lot on our plate? Are we very, very stressed? Do we have just a little bit on our plate and we are okay to like talk about this today? Do we have more room? Where is our window of tolerance? Is it like this big? Is it like pretty big today? Like where are we? What is our capacity for handling this information today? So you can think about maybe there's so many things that have been coming at you. Maybe you've been working with a lot of stressful, tough things recently, but this gets thrown at you. Maybe a client comes in and they're telling you this stuff, but you were not prepared for that. So what even is your capacity to like handle this information and make a good judgment call? How are we just showing up in the room? Is that stress that seems internal actually coming out? Maybe. So what we're bringing into the space, ensuring that we are like a soft landing ground for these questions and answers is really important, but it's maybe not always easy to create. Sometimes I would have to be like, I'd be in a room with a client, they would tell me everything. And typically in my job, we would go and consult with like someone else on our team or a supervisor and just put our heads together. But sometimes I would say, I need to go talk with my supervisor for a minute and brainstorm and I'll be right back. But then I would just go kind of like sit down in a room and just breathe. Maybe I didn't need to consult, but like needed that time to just let my brain process it. So thinking about those things and how do we make sure that we can show up at least at our most best, where we can do our best work. So not just what we bring into the room, but I guess we are bringing these into the room as well. What are our biases and our perceptions? Even educated individuals, maybe we've even dealt with this on our own, maybe we are therapists, we can still have biases and perceptions about suicide. Like think about that. And that's not our fault, that's cultural. That's just how it has been spoken about for decades. But what are these like immediate, just like automatic assumptions we have about this person? We're like, well, why are they dealing with that? They should have just like done this. Why is this such a big deal? Why are they feeling this way? We don't want to feel dismissive or judgmental of them. As we just looked at, there's a specific set of circumstances that has led them to feeling this way. It's not our job to like nitpick those things or judge them. We're just here to be like, okay, this is where we're at. So this is something we may not always think about, but important to spend time thinking about. Ask yourselves these later. If you are going to work with individuals who are experiencing this, what are my perceptions? What's my immediate bias that pops up? What do I think about someone who's dealing with suicidal thoughts? And then don't judge yourself for that. Just think about it. Consult with another professional if you need to. Consult with your own therapist if you have them. So don't feel bad. Just be like, okay, here's what I got. Let's move forward. All of these things, the top two, are going to influence how we react and how we respond. So we can We can obviously neutrally respond, right? There is a neutral ground there. There's also over and under responding. So over responding could be like someone comes in, talks about self-harm, you want to send them to the hospital, like I referenced earlier. That is an over response. Maybe someone comes into a therapist's office and they disclose some of these kind of thoughts, and the therapist just like freezes and is like, I gotta call the crisis center right now, I gotta send you to talk to them. Like, oh, no, the best person to talk to them about is the person who's there, like right then. You just need to listen. And so paying attention to what does that look like and what would be my safeguards if I notice that I or someone else I'm working with is over responding. Under responding, underreacting can be, oh, that person is just trying to manipulate such and such. Oh, they're just saying they're suicidal and they want to go to the hospital because they're trying to get this and this. Oh, they're just trying to get attention from so-and-so. Sure, but those are still very dismissive responses. Those are still things that would lead us to not actually taking the right amount of action that we need to. So, I mean, I've seen that in practice when maybe someone has those kinds of perceptions about the intent of someone's behavior, and then it causes them to not take the highest precautions to protect someone's safety. There's risks inherent with each one. So, we may think we're here to learn about suicidal individuals. We're here to learn about ourselves too, and how we work within this. So as we're on this, I want to talk a little bit, that's hard to read color-wise, but the toll of caring for those who have experienced trauma. We're really just going to talk about traumatic stress, chronic stress, vicarious trauma, etc. for providers. So here are just some definitions. Compassion fatigue. This is one that's a little sneaky. I think it just comes up on us. We maybe don't even know that it's happening. So compassion fatigue is where we just don't have it in us. A provider, or really, it doesn't even have to be a therapist. We just have kind of lost our empathy. We've lost our ability to be soft, understanding, compassionate. And it's not our fault. It's just because of circumstances. Just like it's not someone's fault that they're feeling suicidal or experiencing any mental health condition, it's not our fault that we're experiencing this. It's just a signal, oh, okay, something's off here. I need to treat this. Secondary traumatic stress is when we are hearing from someone about a trauma they experienced. We then experience trauma symptoms having heard about that. That can be direct, one-on-one, someone's telling you about a trauma they've experienced, and then you start to have trauma symptoms. It can be natural disasters. It can be watching too much news and hearing about all of that stuff. There are so many different ways that we can experience secondary trauma without really realizing that we're taking that in. Vicarious trauma is more so with that is more a true traumatic experience. There's more with secondary traumatic stress. It is more of the stress symptoms. Vicarious trauma, you're really it's really deep in there. Just leaving these up for a second in case someone wants to note them. Okay, so again, like I said, we're not just going to talk about all the problems. We're going to talk some about what we do about them. So we're going to start a little bit with that right here. So there's a few points in terms of what do we do about traumatic stress, how do we respond to it. So this is for ourselves, for our workplaces. If we're trying to create, let's say you're a manager somewhere and you're trying to create a system where we don't want to foster traumatic stress. We don't want to foster chronic stress on those that work with us. So what are some things we want to do? Well, we want to avoid re-traumatization. So in the helping fields, whether it's physical, medical, mental health, it can be so common to just be listen to what just happened. Protecting confidentiality, but just sharing oh my gosh, here's what just happened. Whether that's talking about some trauma you've been exposed to, whether that's a crisis that happened. I think about where I worked within 7 counties, we had an inpatient crisis unit on our floor as well. Sometimes we would have to go and respond and help them with physical interventions or restraints. We were all trained in how to do that safely, but people just like talk about those things kind of after the fact. And it's a lot. It is an extreme experience. And so I'm not sure that we always think about like, is this appropriate really to be sharing? Should we share this with this person? Is this person or this group of people like ready and able to, do they have the capacity to like hear this and talk about this? So we want to think about what are procedures for having these kinds of debriefings. So in that scenario, we had a process where you would have just the people who were involved. We would write up a little form, and then we'd go sit. Whoever wanted to could come to a room and just talk about it. You didn't have to. It wasn't forced. It wasn't forced debriefing. It was just planned. And that helped a lot to give people, like, they knew they were going to have a space to talk about it, so it didn't just, like, come out as much in the meantime. A big point about this, and we can just apply this to all areas of our life, not just our work, but adopting a low-impact processing approach. So think literally like what is necessary, just minimum necessary disclosure. Same way with like HIPAA disclosures, you even when you're asked to disclose something, you still just want to minimally do that, just barely, just only what's necessary. So thinking about how many of these details do I actually need to share? Do I need to share the details of what just happened? What am I actually needing? Am I needing support from my coworkers? Am I needing to just express my experience and my feelings? Well, let's start there. And you can just say, hey, there was this really intense thing that happened earlier today. Like, do you have a second to talk with me about just kind of how I'm feeling with that? And then if you're the discloser, just talk about how it's affecting you, not talk about, well, here's what happened first, and then so-and-so did this, and then this person did this thing. We're not trying to re-traumatize people by like, or just traumatize them in general by sharing this information. This goes with details of our clients experiencing suicide, with any of these things that can be stressful. So we want to pay attention to, are we looking out for the well-being of those that we work with? Give warning, hey, I need to talk about some stuff that's kind of intense. We just don't want to come up to them and be like word vomiting about everything that we're going through. We want to ask for consent. Like, is it okay that I share this stuff with you? And then you want to be able to be like, actually, I don't have the space or the capacity right now to be able to talk with you about this, but maybe later, or maybe so-and-so can do this. And then limited disclosure, only talking about what's actually necessary. So this is our first step. We want to avoid re-traumatization of those around us, of ourselves. Beck really loves this visual and loves to include it. And just talking about, like, this is obviously the ideal is balance, right? To be our best selves, we need a balance of all of these things. Work, play, rest. But how common is this? How much do we pay attention to this? How much do we really think, okay, rest is like the foundation. Like, I have to have rest. And not just sleep, right? We need active rest as well. That has to be the core for these things to even have a chance of balancing out. So thinking on how do we create balance for ourselves and in our lives, in our workplaces too. We need to have a little bit of play in our workplaces. We can't just be working all the time. That's a lot of how we survived in our crisis work, is we just were quite silly. Our boss loved if we played pranks on him, so we did that very well. It's a special skill. So whatever works for you in your workplace, but really working to create as close to this very teetering balance that we have. But I think that's part of the image as well, is like if something gets taken off, if something gets knocked just a little bit, the whole thing gets thrown out of whack. And then connect and collaborate. So these are ways we kind of insulate from the effects of chronic stress. So creating opportunities for others and for ourselves to connect with people, connect with nature, even if you don't consider yourself a nature or an outside person. Creating opportunities to do that, to have that sensory experience, does wonders for you and your ability to handle all of these things. Creating opportunities for people to have a meaningful voice, so being able to speak out about their experience. And collaborating to support each other. So a huge thing about suicide care and caring for the individuals working with those that are experiencing suicidal thoughts is collaborating, getting support, consulting with others. Should never be an island. Just like the person who's experiencing suicidal ideation doesn't need to be an island, neither do we as the providers. So really making sure that we are not keeping this information to ourselves for safety and liability, for one, But much beyond that, we're going to be able to share the experience, share the workload, the mental workload, and support each other, brainstorm. Like even, even if you've been working with individuals like this for a really long time, some days it's not our best day and we can't brainstorm the best things. So consulting with others is always key. Okay. So we took a little pause from suicidal information. Hopefully that's helpful a little bit, because we're going to talk about it again. But really, like, what do we do? How do we work with individuals who are at risk for suicide? So we're going to talk about crisis management principles, some practical steps. We'll just go a little bit at length in these, and I hope maybe I'll try to fit in talking about like some questions that you may want to ask and how you want to address this with individuals. And then we'll talk about legal considerations, important stuff, even though it's icky. So these are just general crisis management principles that we want to pay attention to. This is like, let's say you're having a stressful time. You are meeting with someone who is experiencing suicide risk, and you're feeling kind of frazzled or frenzied. Let's just have a little bullet pointed list of things we can go to and think about. So a problem-solving approach. So this means like, okay, let's just take the problems directly. So, okay, you want to think about, I guess that can go ahead with the second one of maintaining a matter-of-fact demeanor. You're thinking, all right, what is the problem in front of me, and what things can I do something about? We cannot change everything. We cannot fix all of it. We can't sit with them 24/7 and make sure they don't do anything. But that's not really the point. So a big thing too about working with individuals at risk for suicide is we're not trying to prevent it, and that may sound strange, but we literally can't prevent it. Like, we can't be there all the time for every individual that is at risk. We just want to plan. So we'll look at a safety plan in a second and talk about like what that looks like and what goes into that. But thinking about how do we plan for all these potential things that could go wrong? We had that one slide that had like 1,000 bubbles on it, and it had the ones at the side that were like, okay, here's the things that could happen immediately. Like they have a relationship loss, they have just some significant immediate event that happens. Those are the things we want to plan for. So let's say, okay, if a person like does have a significant relationship loss, okay, if they are potentially at risk for losing their job, then losing their job would be one of those things we want to plan for. Like, okay, if someone loses their employment, their suicide risk may go up, their thoughts may go up. So what's our plan for that? We're not going to immediately hospitalize them necessarily, but we may want to be like, all right, let's contact their support system. Let's ensure that there's safety plans in place. Let's do all these things. So it's much more about planning than it is about prevention. That's meant to give us some peace of mind too, that like it's not on us, just like the one individual provider, to create safety and prevent this person from acting on these thoughts. Sometimes it's just going to happen. We cannot prevent this from occurring with every individual we work with. We want to, right? And largely we can. But just keep in mind that like it's not only on you to stop them and keep them safe. We want to plan for things, and we also want to be focusing on like how do we help them have a life that's worth living for them. So we're not only focusing on like safety, we're focusing on what are the overall goals for this person, and how do we also work towards that. So thinking about if a person sometimes can come to us experiencing suicidal thoughts, they may assume that we want to take those thoughts away from them. Yes, we do, obviously. But really, when we get down to it, we have the same goal in mind. So we both want this person to feel better. They want to feel better. I want them to feel better. We just have different avenues to get there. And so helping the client understand that too can be really important. Like, hey, I'm literally not against you. We're a team here. We both want you to have relief from all of these things. Suicide is an option, sure, and no one can take that option from you. It's just the permanent option. So let's just like put it over here. It's here. It's there. I can't take it from you. Let's just try some other things first. And that can be a really effective collaborative stance to take with someone. And you're showing that like you understand, you're not shaming them. You're being someone who's like, yeah, I get this. Like this makes sense for you. We want to convey that to them too, that I can see how all of these things have led to you feeling this way. Like I understand that. So also helping them understand that when someone's in a depressed state, when they're in a crisis state, their mind is kind of in tunnel vision, and they're like, all right, this one thing, that's my option. So they think, yes, I'm going to just end my life. That's the solution. It is a solution. So we want to help them understand that too, that like, because of everything that's going on, because of the stress you're experiencing, it limits your brain's ability to see other options. I'm not fully in that, so I can help you think about other options. So as much as we can do to be like, hey, I understand. I'm not trying to like, lock you away in a padded room, but I want you to let's consider some other options. And keep in mind too, if they're talking to you, there's some will to live there. They may not be conscious of it, but it's there. And so keep that in mind too, because it can seem very hopeless. We can feel helpless, like, well, this person's already decided and they got a lot of stuff going against them. So what are we going to do? But keep in mind that if they are alive, there's something there that we can grasp onto. I really just kind of explained the second one without saying it. Modeling openness and honesty. And that goes too with like asking these questions pretty early on. At 7 counties, they now have in place where you're supposed to screen at every visit. So there's questions that are required each time. And so it's like, since we last met, have you had any thoughts of wishing you could go to sleep and not wake up? And then have you had any thoughts of killing yourself? Those are the Columbia scales. If you want to like jot that down, if you're not familiar, there's a lot more of them that kind of increase in intensity. You can kind of gauge the frequency, the duration, like all of those things for them. But really just making it a part of your practice to ask these questions, even if you don't think it's going on. Sometimes I've thought that it's not going on, and then it is when I ask the question. So at that point too, we're just modeling like, hey, this is an open forum to discuss this, and I'm comfortable talking about it. Even if you're not, because we're not always, even doing this for like what feels like a million years, I still don't always feel comfortable asking. It sounds like it, but I'm not. So we want to show that though, as much as we can. Be consistent in your approach, so you don't really want to like go back and forth between like what you're going to do or how you respond to them. Take care of yourself, obviously. I used to have a drawer full of like hot tea. If I knew a tough session was coming up, I'd just go make some. I had a coworker who would just put lotion on, it just seems like a neutral thing, but like that was like a cue for her brain to just like center a bit. Treat crises as an opportunity for growth. So we want to convey this to the client as well. Like, this is an incredibly difficult time for you. It's also sometimes where our brain is most ready to make change. And so frame it for them as an opportunity for growth, and frame it to ourselves. We need to remind ourselves, like, hey, this client's dealing with this. This is a crisis that's going on, but this is like prime opportunity to make good change and make change faster. There's more motivation. Consider what others can do to help. So this is for the client who's experiencing this, of course, but also us. Like, who else can we consult with? Who else can we ask to come in and work with this person? Can we like share in the work here? Can we tag team a little bit? And then use trauma-informed approaches and principles. I just wanted to review these a little bit. There's obviously a bunch of them, but really thinking about trauma-informed. Number one is safety. So we have a safe space emotionally and physically for the person. Collaboration, which is a lot of what we're talking about, like having a very non-adversarial stance, a teamwork stance with them. We want to show we are collaborative in this, right? I'm here to just walk with you through it. So we want to collaborate on like what our plan is. That's big when it comes to safety planning, is being able to collaborate and knowing the client, knowing that like they can be a part of that. We're not just going to write a list of stuff they have to remove from their house. Showing compassion, showing that we are trustworthy, giving them choice. So empowering clients to know that like, yeah, it may seem like you don't have a lot of choices or I'm not providing you choices, but you do have choice. This is your life. So really giving them this empowered, comfortable, as comfortable as it can be, safe space where they can just be themselves, talk openly about what's going on, and knowing we're not going to be judgmental, we're just here to collaborate. Here are some do's of working with suicidal individuals. So be direct. We want to talk openly and matter-of-factly about suicide. We don't really want to beat around the bush. We want to just be direct. We don't want to say, have you had any thoughts of like hurting yourself? I'm going to say, because you have not asked it unless you've said it directly. So unless you've said, have you thought about killing yourself? Have you attempted to end your life? You have to be direct in your questioning, otherwise you have not actually screened. Be willing to listen. Resist the urge to immediately try to make them feel better, to immediately talk about reasons for living, to immediately create safety. Not yet. Be willing to listen. Be that space. And some of the Columbia scales questions, there's one that's like, what are your reasons for wanting to die? So is it this? Is it this? Like why do you want to go through with this? Some people have pause with that and difficulty, and I've gotten feedback that's like, but I would rather just talk about why they want to live. They don't right now. And that's not helpful. So we have to be the one who's okay being like, okay, so why does this make sense for you? Like, why do you want to die? Just letting them speak to it is huge. Like, think about, like, we know this, right? Something that's just in our mind is really big and scary, but when we speak it out, it already reduces it. It reduces the shame. We just have to be willing to listen and not immediately jump in. Let them know it's safe to talk about it. If they can talk about it with us, like, who else? You know? Be non-judgmental. Don't debate whether suicide is right or wrong. Of course, a therapist is supposed to be neutral and not put their values out on the client. A therapist still may have thoughts about what's right or wrong morally. It's not the time for that. That's one of our biases we'd have to put away and pay attention to how it's influencing us. Don't lecture on the value of life. These are just natural human tendencies because we want to survive. We want other people to survive. So yeah, we're going to feel that. Not yet. They need to be heard first. Get involved, be available, show support and interest. We obviously can't be the only one involved, so think about other ways that others can be involved and helpful for them. We do want to offer some hope. So that's, an example of that is where I was saying, hey, when you're kind of in this crisis mode, your brain gets kind of tunnel vision. So I'm going to help you think of some other opportunities, some other outlets and things to do to reduce some of this stress. So just practical hope, practical strategies they can use. And just knowing that, like, hey, there are like research-based things that we know are effective and work to treat this. So we're going to get there. Take action. So lethal means restriction, contacting the appropriate people. When I was working with kids primarily, that was much easier because there was an adult in the home. Sometimes it is the adult in the home that is experiencing the suicide risk. So there's not always other people who are like, yeah, I got that. I'll look out for them. I'll sleep in their room on the floor. I'll, put an alarm on their door so I hear if they leave. It can be very different when it's like just the adult is the one you're concerned about. So working to help them figure out who are my other supports in my life, who they'd be willing to talk with. If I'd had more time to add my own things into this presentation, I would have shown you a video of what that's like to practice. But it can mean being very like matter of fact and direct with your clients and being like, I understand that you don't want to tell so-and-so. It is essential that we find some solution here. So what do we need to do? Let's say it's a firearm. Okay, can we have the ammo locked somewhere on its own? Can we have the firearm itself locked somewhere else? Can we put it outside? We're gonna get to, in a couple of slides, there's just a little graphic, but it's about like, maybe we can't remove every single lethal means, but we can create distance. We can make it to where there's more time required. People have difficulties like locking up all their medications because they need them or someone in the family needs them. Okay, so let's work around that. Let's lock up like most of them and let's just leave a few out. Like what is basically needed for like a couple of days and is not lethal. Sharp items, like any of the lethal means things, if you can't remove them completely, we just want to have time, distance, make it take a longer time to get those things, because the longer time a person has from when the thought occurs to action is less of a chance there's going to be action. These are so often impulsive that if we can just create as much distance as possible, that's going to help us. Fix your face. So When we switched over to telehealth, I realized how much I talked with my face. I did not realize that. I mean, I like knew it, but I was like, oh girl, that's a lot. So not necessarily a negative way, but like really pay attention to that. Like think about when someone comes at you and tells you these things, like what does your face do? Does it drop? Do you have like what happens? Really pay attention to what your face is communicating, because we know nonverbals communicate so much. Seek support. Avoid being sworn to secrecy. This can be kind of hard because we tell people, or we should tell people, that confidentiality has its limits. There's risk of harm to you or others. We will have to talk about it. I usually tell people, like, I'm not going to ideally go behind your back. Like, I want to disclose this stuff together. I'm going to tell you before I have to say something, like if it's concern of like suicide risk, like harm to self, those kinds of things. But people can still be like, I want to tell you this, but you have to promise not to tell so-and-so. But then it could be a suicide risk thing. So we really have to be careful and think about, how do we want to handle those situations? How do we want to respond to them if someone comes at us with something like that? And sometimes, you know, we want to preserve, a therapist would want to preserve the therapeutic relationship as much as possible. But sometimes we have to just let that be a casualty. If we're the one that they lose rapport with because we have to create safety for them and they have to transition to another therapist, okay, you know, we can't decide, okay, well, I'm not going to tell anyone. I'm not going to like try to create a safety plan for them because they really don't want me to, and they're going to be upset with me. We're not going to have a good rapport. Not to be too blunt, but if they're not here anymore, there's not a rapport anyway. And so if we have to be the fall for that, okay. And I've done that before, and sometimes the client stays with me. Sometimes they go to someone else and they're just fine too. It just doesn't matter. So as much as we want to be the calm, gentle therapist who's understanding, sometimes we just have to like do these strict things of our job anyway. So just things to keep in mind. So many things to keep in mind with this. Next is this is like the, I guess, current gold standard, if we want to call it that, of the safety plan. It's meant to be a hierarchy, like a chronological order of events in terms of what to do if someone's starting to experience a crisis. Sometimes when people discharge from like an emergency department for mental health concerns, they'll come away with this. I know a lot of psychiatric hospitals, they'll discharge with one of these safety plans. Does that mean that they really wanted to create it before they discharged? No. They may have just scribbled some stuff on there. So just because they have this, like in their discharge paperwork, doesn't mean anything. But here's kind of how we want to think about it. So warning signs, we want to help them know, like, what are their internal and external warning signs? So what do they notice within themselves of, like, I'm maybe leading to where I'm going to be in more of a crisis? But also like external warning signs. So what do others like notice about them? We can think about the warning signs we already looked at. We could also think about someone like noticing them be more irritable, or noticing them not do their favorite hobbies as much anymore. What are some of these like observable warning signs that would cue someone that they need to like take care of themselves? So we maybe notice a warning sign. Then we go to step 2. Okay, we have warning signs, so then what do? Well, first, we focus on our internal coping strategies. So those, I kind of like the phrase personal coping strategies instead. It's just like you individually. It's not just things you do internally, but it's things you do just yourself. So this is before you reach out to anybody. It's before they're going to like call someone for help, or not help, but support. It's like, what can I do for myself? So maybe they want to go for a walk. Maybe they want to take a bath. Like, what are the things for them? Maybe they want to do a hobby. They want to hang out with their pets. Whatever it is for them that brings some soothing to them. So then you think about, okay, well, if those have not been sufficient in reducing the crisis, then we'll go to the next step. Okay, well, who are people that like can provide a distraction for you? Maybe it's not someone you're gonna like tell all your problems to, but it's someone who you just like don't think about your problems as much when you're with them, or they're just someone who is just gonna be another person in the room. So it's somewhere we're trying to, again, not even create like distance from like lethal means. We want to create distance from the crisis, from the trigger, from whatever is going on. This is a way of doing that. So people in social settings that provide distraction. So do they like a coffee shop? Do they like to go to the library? Can they just go outside? Can they go to the park? Is being at work a distraction? Like, what is it? Let's list as many of these as possible. They may not have a lot of answers to these. My old job required us to like do these the first time we met with someone, and I would get so angry about it because the people don't have answers to these questions. Like if they did, they would not be in the crisis that they're in. So it does lie on the provider at times to help come up with a lot of these things. Sometimes I would just like give people a list and be like, let's just pick some that we're willing to try. So then if that doesn't work, you move next to, okay, who are people I can ask for help? And ideally it's going to be at least one person on there who's pretty stable and could take action, could like call for like assistance or could take them to a hospital if it was that dire. But also just people that they can talk to. And then next you want to write down all the professional agencies they can contact if needed. Local crisis lines, local emergency department, if there's like one that you prefer over another, if your community has more than one. The best place to go for like the best mental health care for them. And then the very last one is making the environment safe, plan for lethal means safety. There's only 2 lines on there. It takes more than that. So I frame this in a couple ways with people too. So for one, it's like, yes, what are the ways we're going to remove access to lethal means? Okay, how are we going to create physical safety in relation to your suicide risk? But also I focus on, okay, well, how can you like feel safe? So like, do you need to go stay with a friend or a family member or something for a little while just because that feels safer to you? Is there a place in your home that feels really cozy and soothing, right? A favorite blanket that you like to wrap up in? Like what physically creates feelings of safety for you from a like deep, basic sensory perspective? That can kind of soften this conversation a little bit because it is tough no matter if it's an adolescent, like a minor, and we're talking with them and their parents, or whether it's an adult, it doesn't matter. It's just a tough conversation. And so this can help soften it a little bit. And you also want to frame like, this is temporary. Any safety stuff that we're doing is temporary. It's not forever. You're not gonna have to have your gun away from you for your whole life. It's just for like now, just for like while the crisis goes on. We can revisit this like every session, like every time you talk to someone, we can revisit this. So helping frame it like that can be helpful too. That like, this is not like you're never gonna be able to be an individual again. It's like just for now. Also framing it of the sense of like, not even just to have these out of your reach, but I don't want these things to like trigger these thoughts in your mind. So these thoughts come up enough on their own. Let's not have anything around that's gonna remind us of them. So that can be helpful too. So thinking for yourself, like what are ways I can frame this to a person that's gonna like soften it, feel less threatening. So I'm not sure if you can get one QR code without the other, but you can try. So you should be able to like get your phone, just zoom in on the QR code. These are a couple websites that are helpful. So Lock to Live, I think it's the number 2, like the website is. If you just want to write that website down, it's lock2live.org, and it's like an interactive website that walks you through, or walks like the individual through lethal means safety. So it kind of has like, in essence, some screener questions, and then tells you, okay, well, here's some things you might want to do. It's very friendly. It's well done graphically as well. So it's a really helpful website as a provider and just as like hand this off to the support person. And then Calm, Counseling on Access to Lethal Means. It's a short little like online training. It's pretty easy to find. You can find it on the Zero Suicide is a website that has it. So you could find it on there. Also just Google. I want to say it takes like an hour, but it just gives you information on lethality, on what are like the primary things to focus on, what should be your priorities in terms of limiting access. This is the graphic I was referencing. I didn't create it, so I can't really tell you all what it means. Is it meant to be like distance divided by time? I'm not sure. But basically we get the gist of it, right? We want to have distance, space, less access, slower access to lethal means. Are these QR codes working? Nice. Does anyone else want to get them? If you don't know how to do a QR code, but you want to, you just pull up your camera on your phone, you zoom into it, and a little yellow thing will pop up, and you click on it. It takes you to the website. I also have, I have a resource list. Could I email it to you guys and you guys could send out? Okay, so it has like these links on there and some other ones too. So I'll do that before I head out today. But it has these on there and some other trainings. Also for the safety plan that we were just looking at, there are apps you can use for that. A couple of them on my resource list are not based in the US. The only reason that's important is because there's a place in them where you can like click to call the crisis line. You don't need to call a crisis line in like Australia. That's what one of them is. But you can input your own numbers in there. So if you're creating a safety plan with someone, it could be good to have them fill it out like that too, and just have easy access on their phone. Pathways to care. So I just want to think about access to care. You know, he was mentioning earlier about just the availability of clinicians who are informed on gambling as a problem and a mental health concern and treating clients with that. So what is access to care for people? Well, if we don't have enough access in that realm, what are other ways we can connect? Are there other behavioral mental health professionals that we can connect with who we trust, who would treat this appropriately? We all want to assume that you're going to encounter non-judgmental mental health professionals wherever you go, but we also know that's not always reality. So thinking about who are the people, the agencies I can have just like a warm handoff, easy transition with. A really key part of transitioning between providers, of providing care for people, is that like warm handoff as much as we can. Transitioning, any kind of transition in a person's life is going to increase their chance of suicide risk. So especially if they're already experiencing that, if they're having some kind of transition or adjustment, it's going to amp up that risk a bit. Transitioning between mental health providers is a huge one for that. When people discharge from a psychiatric hospital, even if they didn't go in for a suicide risk, they have a higher chance of experiencing it afterward, even if that was not their issue before, which is really important to know. So think about how do we create better access for these clients. We, for a bit, we had a partnership with what was called Our Lady of Peace. Now it's University of Louisville Peace Hospital. I had a partnership with them where I would go in and I would do aftercare assessments like on the day people discharged from the hospital with kids and adults, but primarily I just saw adults. And we had just doing that, like just them having that access to like, here's a person from the agency I'm going to go to. We increased their chance of attending their appointment by 50%. Like that's huge for people who don't have transportation, who don't usually go to their appointments, who don't just show up. I wasn't even the therapist they were going to meet with. That's not me at all. That wasn't my role, but we had a 50% increase. So even just something like that simple, any creative ways we can think to shorten the time between care to more directly connect people to care is really key in reducing risk. Okay. We're going to think about legal and ethical considerations. So, here's a few things to just keep in mind. Obviously, we want to document. We're just shifting gears a little bit. Let me say that too. We're getting a little more practical, a little more concrete. We're not talking about therapeutic skills. This is how do we do this? How do we protect ourselves? How do we execute what we've been doing? Obviously, we want to think about this in terms of liability. Typically, there's not a high frequency of litigation of liability claims on things like this, but there are still things you can do to protect yourself. So document your response. Document what you were thinking, when you were thinking it, what was going on. Document differences of opinion. So I've done assessments. I would have to do assessments at like the ER. Go in, like maybe they thought a person needed to be inpatient. They didn't have a bed. They'd call us to do an assessment. Sometimes I would go in and think the client did not need to be inpatient. Big difference of opinion because there would be like a medical doctor who had decided that, and I'm just a therapist. And so I would have to be able to convey, like, here are all the reasons I don't think this is their best treatment right now, and here's all the reasons that I think it's going to be okay. Here are all the safeguards we've put in place, and here's why this could be the okay choice. Sometimes it worked. I'd say 50-50, just depended on the day. Was it 3 a.m. or was it 3 p.m., and what mood was everyone in? But document those differences of opinion. Document so-and-so thought that this person needed to be hospitalized for these reasons. We decided not to hospitalize for all of these reasons. Here's what we're doing instead. That goes with the second one of writing down options considered and rejected. If you didn't write it down, it didn't happen, as we all know. But again, just go back to those principles of just being very matter of fact, very fact-based, distinct. Here's what we did. We thought about hospital. We didn't do it because they could have lost their job. They didn't have childcare. They had a bad experience before. There's not access to care. It's a full moon and there's no beds available. Like, document all of this, because if someone just writes in their note, so-and-so was at high suicide risk for all of these reasons, sent them home scheduled for 3 days from now. That's not going to look good. That literally is bad client care. That may not be the full picture. You always want to write the full picture of everything you thought about, considered, and then why or why not in terms of if you did it or not. You want to show that you went through a good process of judgment. So these are all principles when we're thinking about if there was a lawsuit, this is what would be looked for. Did you show you went through a process of good clinical judgment? Did you explore all of your options? Did you look out for the best of the client? The best of the client is not always inpatient, and that is agreed upon. It is not a requirement, just because even if you were sued, if you were to show that someone was at high suicide risk, you did not put them inpatient, you're not going to be held liable for that if you did all these other things. If you did a safety plan, if you contacted people, if you followed all these protocols. Then showing that you consulted, that's really important too. You may not always have the opportunity or the feasibility of that, but also not even just documenting about collaborating and consulting, just do that. It's always good to consult with others about these things. Okay, so here's our last 4 little sections we're going to talk about. And the first one sounds scary, but don't worry about it. We'll talk about it. So these are just best practices in working with individuals at risk when we're always going to have the idea in mind of like, what if I didn't do the right thing in this session and I send them home and they die by suicide? That fear is always just kind of hanging out back there. So, and then what happens to me if that happens? At what point am I going to be sued? At what point am I going to lose my license, etc.? That can really influence how we react and show up in the room. It's not automatically going to create an adversarial relationship, but if we're coming in with that vibe of like, I got to protect myself, I got to do all these things, I got to put you in the hospital, I got to send you to the crisis center, I have to do all this. We're not even looking at the person. We're not applying any of those principles that we talked about earlier. We are just being like, okay, how can I cross my T's and dot my I's and everything be okay? There used to be the practice of having like no suicide contracts. Sometimes that may still be in the mix, but that idea was clinician and assessor would be like, okay, so we're going to create this paper and it says you agree that between now and next appointment you're not going to try to kill yourself. And everyone would sign off on it. That is not okay. It was, for whatever reason, was in practice. I can see it, right? Because you think you're getting an authentic, like, yeah, I'm gonna like stay safe. But that does so many things, right? That pits us against each other. That shows the client that like this is the most important thing, is that they just don't kill themselves. It's not looking at the whole person and how they feel better. It could give the provider a false sense of security, thinking like, all right, well, they said they're not gonna do it, so, it's all good. So really being sure that we're not just coming at treating these people, thinking about how can I make sure they're not going to die and that I'm going to be legally protected. That is not helpful. Important, not helpful. It could have them to think about, does this person really even care? Like, are they even caring about me personally, or are they just like following a protocol, making sure I don't die? Litigation is rare, and that is a true statement. It is not common. It can happen, but it doesn't need to be what's informing us all the time because the chances are pretty slim. So we don't want to like forget about it totally, obviously. We want to do all the things that we need to do. We want to document appropriately. We want to provide care to the person. We just don't want to be thinking about liability all the time. That's not helpful to anyone. We want to shift our framework. You can pretend like that equal sign has moved over a little. So this goes back to thinking about what are our biases, what are those immediate automatic thoughts that come up for us when we're working with someone. It can be seen. People can perceive that this person is just maybe not very competent. They just don't know how to live. They don't know how to deal with stuff, so they're just suicidal. You know, I don't have to list them all out. We can think about ways that people who are suicidal are framed, you know. It's just another health condition. You know, I think about the fact that, like, just from a practical stance, sometimes when people, like, get on Zoloft or get on, like, some medication, their suicide risk can, like, increase. Okay, if a medicine is causing that sometimes or increasing that, that shows us that it's really not, like, their choice. Like, there's something happening that's, like, leading to this as being their idea. A lot of times people are feeling trapped. It can be comforting to think about, all right, I have a way out of this if I want it. And so just thinking about, like, this isn't just someone who is, like, not stressed, living a great life, and they just decide to end it. That's not what it is. There's, like, stuff going on. They're just as human as anyone else. And so we really want to keep that in mind, that, like, in their minds, whatever is going on, this is an option to them. This seems like a feasible option. And we can get ourselves to a point that we, like, understand that, but we want to work with them through that. We want to show that, like, we have that understanding. Listen to the voice of lived experience. So that means really paying attention to, if you have the opportunity, listening to people who have been through things like this, who've experienced these things, and think, okay, what was helpful to you? What was not helpful? What did people say that was really hurtful? What did people say that didn't work out for you? You know, when I'm thinking about creating a safety plan with someone, like on a smaller scale than this, when I'm thinking about creating a safety plan, I'm like, what do you want your mom, like, not to say? What do you want your spouse to not do? What has been, like, just discouraging to you sharing things with them in the past? It doesn't have to be like, what made you mad? It's like, what things go on that maybe, like, lessen your chances of being able to be honest. So we want people to know that they can speak freely. We want to figure out what it is like to truly experience this level of stress in your life and what's helpful and not helpful. I haven't hit on it a ton, but I want to really make a point to say that hospitalization is not the best treatment for suicide risk. It is a way to create safety. There are many benefits to someone being inpatient when it's a good situation. It can give them time and distance from their stressors. It can be a time for those around them to, like, rally, come up with plans, like, let's collaborate. Their medicine can be adjusted, all kinds of good things, also a lot of bad things. And so they could be traumatized when they're in the hospital. They could potentially lose their job. What if they don't have health care? What if they don't have insurance? You have to think about what are all the things that could go wrong while I'm just putting this person inpatient to keep them safe. So it's also just research proven not the best mental health treatment for it. There's also a higher risk of suicide after discharge. So let's keep that in mind. So it may be like, okay, in these, like, 3 days, you know, if it's a hold, or this week, they're gonna be safe. So that gives us peace of mind. It's not really gonna progress their treatment in any way. So sometimes it's necessary, but just keep in mind, there's a lot of reasons we want to, like, be considerate when we're deciding one way or the other. Clients who are experiencing this need to have suicidality seen as a response to what's going on, not a mental illness. So it's not something wrong with them. It is, unfortunately, a natural response to things that happen in life. So they need to understand that we understand that. And I also think it's important to convey that to the clients themselves too. Like, this just happens, you know? Like, it can be a question you ask, you know, when sometimes when people have all the things going on that you have going on, when some people feel the way you feel, it can be just kind of natural to have some thoughts about suicide. Like, has that come up for you at all? They're just going to say no, or they're going to say yes, they're going to tell you. There's no harm in just being like, what's going on? Even if they've said before, like, oh, I have religious beliefs that, like, suicide's wrong. Those are still good people to check in with. Like, I know you've said before that this is, like, really against like who you are, what you believe, but sometimes this just comes up for people when all this stuff's going on. Like, have you had any thoughts, even like little thoughts? They still may say no, even if it's going on, but you're reducing the shame in that situation. So I've already been speaking to this a little bit, but I'll go to the bottom one where it says type of suicidality. So there's a couple different things there. For one, there's suicidal crises that are like immediate, responsive, reactive to a stressor. Those are ones where we really need to focus on like immediate safety. How can we plan for these events? How can we plan for these stressors? What do we do practically on the ground right now? There's more chronic type of suicidality where maybe they're experiencing it for years and years. It can serve all kinds of purposes. Sometimes it's like emotionally regulating. I had a client who we later found out had obsessive compulsive disorder. They didn't tell us all the symptoms because she thought it was just like normal and how everyone thought and experienced life. So we just didn't know. But part of her OCD was something would go wrong or stress her out, and she would just think like, I want to die, like over and over again. And that comforted her, like that calmed down the other anxieties. She still was at risk. Like this client had still attempted suicide, was still at a heightened risk state for sure. But learning that totally shifted the way we provided treatment, like completely shifted it. I was like, oh, well, okay, we need to work on those symptoms. Like we're not gonna get anywhere if we don't work on the OCD and anxieties. So you really want to pay attention to and make sure you are looking at is there a certain type of suicidality that's going on here? And that's it. So I know it's like incredibly condensed and like so much information, but anyone have like thoughts, feedback, questions, things you want to share about your experience?
I just thought that the last thing you said about looking at the type of suicidality,
Mm-hmm.
how important it is for us to focus on that it's not an incompetence, whether that's with the client or with the family and natural support,
Mm-hmm.
for any aspect of mental health disorder that our clients are coming to us with.
Mm-hmm.
So important
Mm-hmm.
because of the stigmas
Yes.
that are already there.
Yeah.
I've seen it professionally, personally, with situations,
Mhm.
and I think that's a really nice thing to take away.
Yeah, it's like a nice reframe to think about it. And I have to remind myself too that like I know these things about suicidality. Like I know that it can come from different places, but like we got to help the client understand too, right? Like help the people dealing with it know that like there's not a stigma. It's just like sometimes it just is, you know.
One of the issues we run into sometimes with working with gamblers that have problem gamblers that are having issues with thoughts of suicide is they start to view this as a kind of selfless act. For example, taking out
Yeah.
Life insurance as
Yeah.
a way to kind
Yeah.
of recoup the losses or make things right with their family. How would you recommend working with individuals in those kinds of cases?
Those situations that seem hopeless, that seem really tough to come out of, we just typically take it really small, like one step at a time. Like, okay, like today, like we really want you to be safe. Let's think about the reasons that's important and how can we do that like today, like right now. And you want to get into like what are another aspect of that. There's a training called CAMS. It's the abbreviation. Love it. It is so helpful because it's a really cool way to frame suicide. It sounds so weird, but in like that's very much how they talk about like, yeah, it's an option for you, sure, but it's just not the option we're going to go with like right now. But that model breaks down like, okay, let's look at like self-hate. Let's look at there's like 5 things. Yeah, it's like I know something like very simple. CAMS. Yeah, and there's trainings on it like all the time. But that one, those have been really helpful in my like chronic, really like deeply ingrained situations where it's like, okay, let's figure out what is actually going on. Like, is it self-hate? Is it desperation? Is it like this anguish, this like psychic pain? Like, what is it? And helping them gain some perspective on like the nitty gritty of what's going on has given some movement to those kind of situations. So has anyone had like successful strategies with clients like this?
I've used CAMS a couple of times.
Mhm.
I got certified in it a while
Mhm.
back, and it is very effective
Yeah.
at that kind of Socratic, the first lesson where you
Mhm.
have the Socratic questioning,
Yeah.
peeling the onion to
Yeah.
get to that core thought.
Mhm.
But the issue that we run into with problem gamblers in a lot of cases is, yes, there is a behavioral issue and
Mhm.
compulsion, but addressing those external factors and involving the family as well and the
Yeah.
loved ones that may have been alienated, and addressing
Yeah.
the suicidality that may be on their part also is a bit of a difficulty because
Sure.
CAMS is more designed for individuals.
Right. Oh, sure. Yeah. 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 And that's that's a big theme in like any of this work is like reducing the shame. So I think how can we get at that? Like, is there someone to connect with that like we can like externalize some of those thoughts and feelings that are contributing to the suicidality? Because it is so individual, it's so internal, and sometimes it still is individual when it's between the person and the therapist, right? It's like out there in the world, but like it's still pretty closed door, literally closed doors. So that's what I think about too, is like how do we mitigate that and the effects of those things. I don't know how much research there is too. I've seen some research about like specifically problem gambling and suicide, but obviously there needs to be more, you know, and like what is most effective? What do we do? And every situation so individualized anyway, you know. Yeah.
Dr. Clark mentioned in the introduction today that I'm the professional advisor for this group. And in that spirit, I want to make some comments. First, I believe that yours has been the best presentation of this sort that I've ever seen in my career. And there were so many pearls in there that it's a little hard to pick anything out. But as an old man, I will mention that in 1975, when Jim Beck and a few of us were trying to pioneer cognitive behavioral therapy, the idea of automatic thoughts was a hard sell. And the idea of automatic thoughts as part of an apperceptive mass was an even harder sell. And I was impressed that you did it. You integrated the idea of automatic thoughts as if it were just always there, but it was not. And you did it almost automatically, I might say. The next point is that I take what you said to be that that the therapist and the client should not debate the value of suicide. But in cognitive behavioral therapy, it's very important that the client himself or herself have that debate. And one of the techniques for doing that that was developed is the so-called double column or pro and con technique. So I'm assuming that you would endorse that, but I want to clarify it.
Yeah, I've definitely done that.
It's a very powerful technique for getting the internal cognitive debate in the patient going without being directive. And then third, you mentioned the importance of following the research. Now, one of the problems that I've seen in our mental health field over the years is almost a prototype of the difficulty we have in teaching math in elementary school. And that is the ability to evaluate research. The idea of a research-based treatment depends upon your knowing how to evaluate the research. And that requires a knowledge of statistics and a whole lot of things that most programs these days give only lip service to. And in our council, we have the statistics advisor who tries to keep us honest about what is good research and what is not. And in one of the presentations here, he will try to demonstrate that what quality research can contribute. But the other side of that is what inept evaluation of research, particularly that sounds good but is not good. I think we have to pledge ourselves as therapists to the scientist professional model, which requires that we know how to look at research objectively. And if we don't, we have to develop a consulting relationship with people who will tell us what's good research and what's not.
Appreciate your comments. I do just talk about automatic thoughts like it just is.
I'm sorry.
I said I do just talk about automatic thoughts like they just are. Yeah. And that's one of the questions that like was really interesting to me to learn about too, was to just ask a client, like, how controllable are these thoughts? Like when these thoughts come up to you about suicide, like how quickly are you able to divert to something else, or are you? And I was like, well, what an idea to just frame it to them as like, these are just thoughts. You don't have to do anything about them. So helping people like gain perspective in that way too. Thanks for your comments.
You had mentioned earlier about how.
One second, boss. If you guys want to do Q&A, please use the microphone.
Oh.
That way everybody at home can hear as well.
We can hear about here.
Well, yeah.
You had mentioned earlier about definitely watching out for your face and everything as one of the things whenever you're talking to someone. What I've learned with being, especially with crisis line, is your tone. Is being very careful with your tone, is because they can really hear if you're actively listening and if you are actually really caring. And that's where asking the questions needs to be more on, okay, I'm, even with the gambling and with suicide, it's being able to directly say, hey, I'm here to listen, and I do hear of you going through these issues. Would that, though, be something you would also talk about, is trying to figure out tone?
Yeah, that's so key. Should just add that into the slide. And that's also, I think, about like practicing these questions and really thinking about it, being aware of ourselves, because if we got some biases, they're going to come up in our tone, whether we think about it or not. Yeah, that's like a great point. Yes, I need to like add that in next time. Because we also can think about instances whether ourselves or like others have maybe had a tone and they didn't realize it. So asking for feedback from people can be really helpful. Yeah, that's huge, especially on the phone. Like, there's nothing else but your tone, you know? Yeah. They can probably hear if you're scrolling your phone, you know, they can know you're not attending. Good point. Yeah. So this is my contact. My email address is very long, so that's why I wrote it that way. Reach out to me about anything, whatever. I left Beck's email on here too, because he is like the suicide prevention like coordinator and coordinates lots of trainings and stuff. So he and I do trainings together sometimes, but then he'll also like coordinate ones that I do. So he's a good person to still have contact for if you want more information. Thanks for having me.